Thank you for joining today's session, which is entitled, Should We Tell Young People They Are at Risk for Psychosis? An International Perspective. First, I want to tell you a few things about any SIRS symposium that you may be watching. We understand that the slides may lag or be slow at times. Each speaker will present their slides, and I will moderate a brief Q&A portion at the end of this session. If you have additional questions after watching the speaker, we recommend emailing them your questions. Be sure to promote your science, colleagues, institutions, and SIRS by posting comments and pictures to Facebook and Twitter. Please remember to use the hashtags SIRS 2020, SIRS, and simply schizophrenia. And don't forget to retweet, repost, like, and share, and comment on other social media posts. As a brief introduction to this symposium, in 2019, the SIRS Ethics Committee Symposium focused on the ethical perspective of psychosis prevention, an excellent presentation in Orlando, Florida. In the Q&A, there were many questions about labeling of psychosis risk, for which no data had been presented, and for which there was a general assumption among the speakers that such labels are stigmatizing, such that the harm and risks of labeling seem to outweigh the benefits of the risk label. However, data do exist that show that diagnosis and labels related to psychosis and its risk states can have real benefits, providing organizing information to young people and their families, especially if done within the context of thoughtful psychoeducation that includes strategies for accomplishing life goals. Withholding diagnosis could potentially be interpreted as paternalistic and a threat to the ethical principle of autonomy, reifying the stigma of the psychosis label. This symposium has international representation and includes research specifically on psychosis-related labels, their proven risks and benefits, and strategies for diagnosis-related psychoeducation and normalization. Not all of the speakers agree, so it should be a very interesting symposium with a lively Q&A. Our first speaker will be Carmel Loughland of Australia, who will present a body of research on schizophrenia diagnosis with qualitative study of patients and clinicians in respect to non-disclosure of diagnosis and specific training for how to deliver diagnosis. The second speaker will be Yulia Landa of the United States, who will describe her work in the adaptation of Loughland's model for individuals with psychosis risk, including training of clinicians and psychoeducation for young people and their families. The third speaker will be Alexandre Loch of Brazil, who will describe his surveys of psychosis-related stigma in Brazil, as well as the normalization of psychotic symptoms within religious organizations in the cultural context of Brazil. And then finally, Danny Koren will discuss his research piloting the use of labels for psychosis risk that focus more on symptoms and functional impairments than risk for later illness. At the end, there will be a discussion that I will lead. At this point, it's my pleasure to introduce Dr. Carmel Loughland, who will give the first talk.
Hello everybody, thank you for coming along to this Zoom presentation. I'm the first in our group to present today, and as you are aware, we're going to have quite a large series of presentations around this topic. What I wanted to do is to really come to you with that question around whether or not we really should be telling people about their diagnosis or their risk factors, especially when they are young, and what the implications of that might be. I've shown you this picture here because I think in the controversy around this particular topic, what would be useful perhaps is for us to hear the voices of those people who have lived experience with this. That is the clinicians and the patients themselves who've had a diagnosis of a mental illness and their carers, their family carers who've been involved in that process. This doesn't mean that this presentation has all the answers or is able to dictate what clinicians themselves might do, but it's, as this picture shows, it's like striking a match and trying to bring some light to a topic that is often very difficult to discuss and quite controversial at times. So the information I'm going to report to you today is a bit bittersweet. There's some aspects to this that you may feel very uncomfortable with, or that may be a little upsetting in some ways, because it's hard to imagine sometimes that people might have said some of these things. In other ways, it's quite sweet in that what you're hearing is people's true account of events. And although it can be difficult to hear these events, this is not to undermine clinical practice, this is not to undermine clinical judgment, and it's certainly not to say in any way that clinicians have all the answers here. They certainly don't. But neither does anybody else in this field. And the people who are coming to this, particularly the patients and the carers who were interviewed in this setting, really wanted to help and advance this situation, which is why I'm presenting it here today. So what I'd like to do is talk to you a little bit about the methodology here. So we used a qualitative approach. We used 3 what we called expert groups, so people who had been through this experience themselves, and they were people with schizophrenia, their family carers, and also mental health clinicians. Now the numbers here are relatively small because it's a qualitative study. I can assure you that saturation was actually met in all 3 of these groups. We did this recruitment within the Hunter New England Mental Health Service within Australia, and I'll take you through that a little bit to show you that region as we go into the next slide. But for the moment here, the way we collected data was using semi-structured interviews, and we did the analysis using in vivo, along with a whole range of sort of various thematic structures that we used to pull that the themes out. Now, to give you a bit of idea about where I'm talking about in terms of our recruitment, we have a picture here with Australia on the right-hand side within the context of the whole world. On the left-hand side, I have a picture of Australia with all the states in different colours. And in the blue New South Wales state, I've lifted that to the top left-hand corner there, and you can see in the light blue the Hunter New England region. Just below that in the picture is the actual region itself that takes into account quite a large area. You know, this is such a diverse range of people, going all the way up to the Queensland border and right down to the middle of New South Wales. The red area here is where I'm located in the Newcastle region. This meant that we had the opportunity to talk to people from rural and remote regions, as well as metropolitan regions when we're conducting this particular set of interviews. Now the results here, hopefully you can read these easy enough, and I've tried to set them side by side with each other in tables. Hopefully this works for you well at your end. But one of the questions we ask is, should we actually tell people about their diagnosis? And the views on either side were relatively the same. Most people said, yes, we should tell people their diagnosis or risk factors for diagnosis or illness. For the clinicians, the majority who said, yes, but there are conditions that apply. They felt generally that most people knew that they were unwell, and so beating around the bush and not telling them what their illness was wasn't particularly helpful. But they were mindful that if you were talking with very young people, people with their first episode, people who were highly vulnerable, then they would use their own judgment around whether now was a good time or not. But generally the feeling was, yes, I would definitely tell people. There were only 4 mental health clinicians who thought that they would not and did not in practice tell people. And generally they did so because they felt that it was very daunting, especially that first episode for people. They wanted to be careful about labelling people with serious diagnostic criteria around schizophrenia, for example, and they wanted to also make sure that they weren't further traumatising people who've already been through quite a lot. Now, as I said, they were particularly concerned about those experiencing first episode, and in particular young people. They thought there was a lot that could change, and they didn't want to make a big deal out of a diagnosis at that point. For the patients and carers themselves, who we tend to collectively call consumers, while the majority of people really wanted to know what their diagnosis was, the importance here was about knowledge, because knowledge was power. You can see I've got two quotes here, one from John and one from Jeremy. John was saying he remembered being in hospital. No one told him he had schizophrenia, and that was a big mistake for him. He felt like he really didn't understand what was happening to him, what he was being treated with, and why. And for Jeremy, it was very much a case of that hearing the word that you have, or being told that you have a diagnosis like schizophrenia, was not a nice thing to hear. It was nonetheless a relief for him that he finally had a diagnosis to pin what was happening to him on. The people, and there was only a very small number, 6 in total out of this group, who said that they didn't want to know. And it was mainly around the fact that it was, for some of those people, that they felt that the doctors really didn't know what they were talking about anyway. And I'll come to this in a moment, because for many people, they do have multiple diagnoses over an illness period. And for some of those, that really acted as a factor for them around why they should or shouldn't believe any doctor when they get a diagnosis at all. And again, the second quote here from Elaine really is that, you know, they told us all sorts of symptoms and illnesses in the beginning, and in the end we just didn't want to know about it anymore. So it wasn't like they were saying, no, I didn't want to hear what my diagnosis was. It was more I felt, or I interpreted this as feeling quite burnt out from having multiple diagnoses perhaps, or multiple information presented to them, and they just couldn't comprehend it all in the end. When it came down to reasons for and against here, again with the clinicians, the main reason for telling people is that they realised that this provided a sense of relief for the people they were treating. It also allowed people to gain access to information, whether that be through the internet or information they were providing, because importantly, if you don't know what you have or what the problem might be, you then really don't know what information you should be accessing it to familiarise yourself with that. And as we just discussed earlier, people, the clinicians were saying, well, people already know, so there's no reason to beat around the bush with that. The main reasons for people, for clinicians not talking about diagnosis, was around uncertainty. And there was a lot of caveats about uncertainty. There was uncertainty about diagnosis, whether it was this illness or that. There's uncertainty about how people might react to the diagnostic information they're receiving. There's also uncertainty for the clinicians around how effective their treatments might be. And if it wasn't very effective, that kind of undermined the diagnosis they were giving as well, and would mean they would have to go looking for some more information, and that was fine. They felt that they needed to do that if the medication wasn't effective. And also uncertainty about when to tell somebody about their illness, and we talked about patient characteristics like age and vulnerability before. When it came to the consumers that we interviewed, the main reasons that they were for being told was that for many of them, they had gone long periods of time without being given any diagnosis. And it's quite sensible from a clinical point of view to talk to people about symptoms only and treatment around those symptoms. But one of our people that we interviewed here had gone 16 years without actually being given a diagnosis. Now, that was in his memory. Whether or not that was true or not, that is debatable. But for him, he doesn't remember ever being told what his diagnosis was. And that meant he didn't really know very much about what he was being treated for, why he was being treated that way. He became homeless, he wandered around. He really had a great difficulty in coming to terms with his illness. Once the way he found out about his diagnosis was actually on his file for when he was going through a tribunal situation, and that's when he recognised the word and what it meant about him. The other thing that was really clear, particularly from the carers in this situation, was that many of them had great difficulty knowing what was going on for their loved one, the burden of not knowing what that was, and the suffering that they all felt as a consequence of endlessly searching for what was causing the problem for their loved one was a really big issue for them. So burden became a big issue in much of the discussion that we had. The against people, as I said, were really a lot about burnout. Much of the reason they didn't want to know was they felt that they'd been, for years and years, been getting all this information from their clinicians. Nothing was ever clear. Here was another diagnosis. Here was another set of symptoms. For some people, they had actually gone through a long list of diagnoses from depression, eating disorders, borderline personality disorder, whole range of psychotic spectrum disorders. And so in the end, it got down to really we don't matter. The other thing, of course, is that people can often be afraid of the diagnosis, particularly around severe diagnoses like schizophrenia, because they often have had a family member or someone else they know that may have been diagnosed with that illness, and that was more the concern. So one of the things that came out in our discussion also was that the more that clinicians spoke about what this really meant for people, the easier it was for them to understand and not feel so afraid. One of the big areas or big issues of discussion that came out was around hope and recovery. And one of the messages that I want to leave with you today is that for most people, having a diagnosis or being told that they are vulnerable to a psychiatric condition is one thing. Giving people hope about that in terms of how that might be treated, that illnesses can be managed, that people can have a quality of life despite having a mental illness, and that even if you do get one, recovery is very possible for people. That makes all the difference and made all the difference. And I've included this quote here from Alex, who summed up really all of those points, I think, extremely well. What I want to also just let you know is there's a series of papers out by our groups and others, these three happen to be from us, that are providing this information in much more detail than what I've been able to do today. We continue to work in this space. We're looking at lots of research around people's views of diagnosis and treatment and so on. But here are a number of papers that if you're interested, we welcome you to go and look at these papers and look at many of the quotes in them from the people that we have talked to. One of my last slides is to introduce you to our Australian team that includes Brian Kelly, Hassan Rat-Sandhu, Sue Outram and Philippa Ditton-Fair. This wonderful team of people have worked really hard here in Australia to bring this data together. We work with our colleagues in the US who are also collecting data and worked with us around developing communication skills training programs, and we hope to be able to continue to forward that, and you would have heard us presenting on that previously at this conference and others. But I do ask you, if you ever have any questions about this, do please reach out to myself or any one of these team members. I thank you for your time in listening to my presentation today. I know that there is a series, as I said, that this is involved in our contact email information will be available to you. And if you have any specific questions about my presentation, we hope we get a chance to talk those through in the Q&A, or you can contact me via email at any time that suits you. Thank you for your time, and I'll finish my slides there.
So I'd like to thank Dr. Loughlin for a very good talk. Very important to pay attention to the voices of individuals with lived experiences, including both clients and also clinicians. It's my pleasure to introduce next my colleague at the Icahn School of Medicine at Mount Sinai in New York, Yulia Landa, who will discuss the adaptation of methods that Dr. Loughlin has developed with individuals designated as clinical high risk. Thank you.
Thank you very much, and I am excited to continue our symposium. I am going to focus on discussing, communicating with patients and families about psychosis and psychosis risk, and specifically focusing on educational models for patients, families, and clinicians. The work I will be speaking about is supported by multiple grants, including federal grants and private foundations. So clinical high-risk concept has been introduced in mid-90s. Alison Young and Patrick McCorry operationalized CHR criteria, and CHR typically identified by a structured interview for psychosis risk syndromes, SIPs, or comprehensive assessment of at-risk mental state. Right now, there are more than 80 CHR clinics established around the world. And still, it is a question: what are the benefits having CHR programs? What are the concerns having CHR programs? And how do we want to talk with people, young people at clinical high risk for psychosis, about psychosis and psychosis risk? There are definitely benefits in having such programs and discussing psychosis and psychosis risk. That benefits include that we might be able to prevent the development of psychosis, or at least we might be able to delay the onset of psychosis. We might be able to improve people's course of illness. We might be able to restore and help them maintain their functioning. And if these young people will go on and develop psychosis, they will be already in a supportive program, and treatment could start earlier, and therefore we can also reduce the duration of untreated psychosis. However, there are concerns. If people are treated for psychosis risk, they might never develop psychosis. However, one concern, if we give them medications which have side effects. Stigma absolutely exists, stigma because of the word psychosis. So the question is, how do we deal with this stigma? People might have anxiety of developing psychosis, and the stress and anxiety could further contribute to their symptoms. In addition, clinicians might be uncertain how to communicate about psychosis and psychosis risk, and might not have training and confidence to be able to do that. In Mount Sinai, we have been doing work on both identification of young people who might be at risk for psychosis or have developed for psychotic episode. We identify people by screening, typically using PQB, prodromal questionnaire brief, and also we provide training for clinicians who refer patients for further evaluation. And we use SIPs at CARMS to evaluate patients to see if they might be at risk for psychosis or develop their first psychotic episode. In order to provide feedback to patients and their families about condition of psychosis risk and or psychosis, we have developed a program called ComPsych, Communication in Psychiatry, which is based on programs developed in cancer research, and also based on qualitative interviews that we have been conducting together with our Australian collaborators on what are people's preference in receiving bad news of diagnosis of psychosis or information about psychosis risk or clinical high risk. And then for people who meet criteria of clinical high risk, we have developed psychoeducational program. One program is Begin, and another program is CBT-based group and family-based cognitive behavioral therapy. And today I will specifically talk about ComPsych program, Begin intervention, and group and family-based CBT. So ComPsych program is based on communication skill training, discussing a diagnosis and prognosis of schizophrenia with patients and families, which we adapted to psychosis risk and psychosis. We typically train clinicians how to provide this information, and we have a training on didactics, which includes theory and research on communicating prognosis and diagnosis of psychosis and psychosis risk, information about clinical high risk. We teach core communication skills. We teach how to conduct family meeting using a consultation model where we would discuss diagnostic information about psychosis and psychosis risk, discuss the prognosis of psychosis risk and psychosis, and treatment option. Importantly, we then have practicum where clinicians can learn through working with simulated patient actor to practice these skills. So here are core communication skills that include empathic communication, questioning, agenda setting, checking with the patient about information they received, information organization, how to organize information that we are presenting to patients and families, and shared decision making. And then clinicians learn through practicum, simulation, doing role play with simulated actor patient. And the advantages of doing training this way is that clinicians can try their new skills. They can receive feedback. We usually video record these role plays and then review them together. We provide a lot of feedback, focusing on clinician strengths, areas of improvement, and also trying a different approach. Here is ComPsych SIPS feedback meeting model that we developed to provide patients and families information about psychosis and psychosis risk. Here are general principles. How do we usually do it? We want to provide information in a clear, concise, and empathic way. We want to use patients' own language. We want to focus on symptoms and experiences, not diagnosis per se. We want to check with patients with information, which information would be helpful for them. We also want to discuss research and clarify that statistics and research findings provide only general information and average. When we're discussing psychosis and psychosis risk, we maintain a recovery orientation, and we want to instill hope. And we always want to focus on patient strengths. Here are the steps of how to discuss psychosis risk. Here are steps that we typically follow in a SIPS feedback meeting. Let me go over these steps. So we want to prepare for the meeting. We want to schedule the feedback session. We want to consider what information to convey and decide ahead of what would be important for the patient. We want to decide what providers and family members to invite to this meeting, choose an appropriate setting that would minimize interruptions, arrange a setting in a way that facilitates collaboration, and we also want to print and prepare handouts and materials to provide to patients and families. We then want to set an agenda with the patient and their families, and we always want to start with their agenda, what they would like to discuss and information they would like to receive. And then we also declare our agenda items, which would include review of SIPS, providing information about SIPS results, and discussing treatment and next steps. We will then review SIPS with patients and families. We would explain the purpose of SIPS, explain psychosis model, what psychosis is. We would integrate stress vulnerability model in explaining psychosis to normalize patients' experiences. We would also explain psychosis risk, elicit and address questions, and offer SIPS fact sheets that we developed. Step 4, we will provide information about SIPS results in a way that will be understood of patients and recalled. We would ask patients permission to review their symptoms again. We would summarize symptoms and experiences that we discussed with them before and explain which criteria patient met on SIPS. Step 4, we will provide information about SIPS results in a way that might be understood and recalled by patient. We would avoid jargon, address all the questions, repeat information if needed, write or draw information if appropriate. Step 5, we want to respond empathically to the patient's and family emotion or experience. Step 6, we want to explain prognosis and possible outcomes in a manner that is sensitive to the patient's needs and promotes hopefulness. Step 7, we want to respond empathically to the patient's and family emotions. We would then want to discuss our treatment options. And specifically, now I'm going to talk about several treatment options that we typically offer. One is Begin, and another one is group and family-based CBT. Begin is a psychoeducational intervention developed for individuals with psychosis risk and their caregivers, developed by Shayna Herrera, and it's been her career developmental award she received. This is 5 sessions, 45-60 minutes per session. A patient can participate with or without the caregivers, depending on their choice. It's a structured intervention using slideshow presentation on iPad, and it includes education, discussions, activities, and homework. And patient uses Apple Pencil to record notes and engage with activities. Begin provides education on psychosis risk. Patients do self-assessment of their symptoms, they identify their goals, they discuss options for treatment, and make decisions about next steps. And this is group and family-based CBT intervention that provides skills group for patients, separate skills group for their families, and individual sessions. The goal of GFCBT, group and family-based CBT interventions, are to prevent or possibly delay a transition to psychosis, to help patients restore or maintain functioning, develop strategies for resilience to stress, to enhance youth and family ability to communicate about difficult symptoms and experiences, to reduce stigmatizing beliefs about psychosis. We also want to facilitate positive family and peer environment, and to facilitate use of skills learned in time-limited CBT. Our treatment model is based on research of how people develop psychosis, which factors contribute, and specifically we want to teach young people about cognitive biases, reasoning strategies, and we want to decrease isolation by providing family-based and group-based intervention. In groups, people learn CBT skills, and they work together to apply these skills to reevaluate their stressful, sometimes suspicious beliefs or stigmatizing beliefs. CBT is a very good tool to help reduce self-stigmatizing beliefs. And we also have individual sessions in support of CBT group skills, as well as we teach family members cognitive behavioral therapy skills and how to interact with their loved ones at home, how to implement CBT at home. We teach family members skills that we adapted from CBT for psychosis training for clinicians. And we teach them the skills by explaining the skills, teaching them how to implement the skill, what to do and what not to do, and then role-playing these skills. We conducted a series of qualitative studies looking at people's experience with CompPsych model, with Begin and group and family-based CBT. This qualitative work shows us that participants, patients, and their families have experienced CompPsych feedback as normalizing, and participation in this feedback led to improved communication about symptoms. Specifically, assessment tips and CARMs provided vocabulary. Youth became more open to discussions of symptoms, family members became more understanding of their experiences. They also talk about benefits of learning about clinical high risk, that it is helpful to have a name for experiences, and also they can now distinguish between psychosis and psychosis risk. Many young people said that receiving information that they are at clinical high risk state was providing them a relief because they were afraid that they already developed psychotic illness such as schizophrenia. Here is a quote. My son learned the fact that there could not be a diagnosis because his problem was so early on. What they call the pre-psychotic break was enough for him to understand where he was. I think without having a diagnosis, it wasn't good for him. He did not know whether he was dealing with bipolar or schizophrenia or anything. And the reality was that he never got to that point. Here are selected themes from qualitative interviews with individuals after they completed begin intervention. Patients express higher self-awareness, autonomy, ability to make informed decisions. Also, they said that begin fulfilled need for CHR-specific education on symptoms and possible outcomes, and provided safe and collaborative therapeutic environment to discuss and ask questions. Here is one quote. It helps you become more independent. It helps you treat your own symptoms, helps you recognize your own symptoms and how you can change it. Group and family-based CBT provided normalizing information about psychosis and psychosis risk and help people reduce stigma. Here are some quotes. I'm just going to read two of them. I think knowing that there were other people going through the same stuff, I think that was really helpful. I guess that would be most helpful. First of all, my daughter learned that she's not alone. She's not an exception. And this is quite a frequent problem in modern society. So she's learned not to be ashamed of it, not to hide it, and feel like an outcast. She learned that it's quite common and she shouldn't keep it to herself because she can always find friends. Our patients also talked about learning about clinical high risk and attenuated psychotic symptoms. And by learning about them and learning how to deal with these symptoms, how to cope with them, they started feeling better and more in control of their experiences. I was able to realize that I did have a paranoia problem, but I also realized that it didn't progress as far as a lot of other people, and that I could learn skills to try to help my paranoia problem and try to get rid of it. I learned a lot of new things about the range of this disorder and ways how to cope. In summary, we can conclude that SIBS and CARM's evaluation and education about psychosis and psychosis risk can be beneficial for help-seeking patients and their families. Training for clinicians on how to discuss psychosis and psychosis risk with patients and families can be beneficial. CBT can decrease stigmatizing beliefs about psychosis, and group and family-based CBT can be particularly beneficial because it helps in normalizing patients and their caregivers' experience. And we need more interventions. We need to provide public education and develop interventions aimed at reducing stigmatizing beliefs about psychosis and psychosis risk. I am delighted to answer any questions people might have and to collaborate. Here is my contact information, and I wanted to say thank you to our wonderful team and collaborators.
Thank you very much, Dr. Landa, for an excellent talk. It's very interesting to hear about the actual steps to take in providing this kind of information. It's my pleasure now to introduce Dr. Alexandre Loch of the University of Sao Paulo in Brazil, who studies clinical high risk and has thought about this question of stigma in the particular instance of Brazil, where religion is very important. So it's my pleasure to introduce Dr. Loch.
Hi, thank you, Cheryl. Thank you for putting this together, and thank the SIRS for allowing us to present our work in this online symposium. It's a great opportunity. So I'm Alexandre Loch. I'm from the University of São Paulo, Brazil, and my talk will be about the role of religiosity in prodromal psychosis and psychosis conversion in the Brazilian SAP cohort. Issues in labeling schizophrenia and at risk for psychosis. Well, first of all, I would like to show you this picture. This unusual picture. This is what we call a spiritual surgery that's conducted in Brazil. Many people with cancer and severe diseases, progressive diseases, when they lose faith in traditional medicine, they often look for such religious practice. This is a medium. She incorporates the spirit, usually of an ancient doctor, and then she tries to perform this surgery. You can see here 2 scissors in the patient's nose, and it has a series of ritual, and this is in theory performed by the spirit that's possessing the woman's body. So this is just for you to see the intricate relationship between medicine and religion, and this is especially true for psychiatry. So a little bit about Spiritism. This is a religion that came after Hippolyte Rivel. This is Allan Kardec, who wrote the Book of Spirits. And it's all about reincarnation. That is, when you die, you keep living, you leave your body, but you keep living as a spirit, and then you reincarnate in another body, in another life. So it has concepts like mediumship is the central concept of it, which enrolls psychography, psychophony, and clairvoyance. So the first is the act of writing, as if a spirit would dominate your hand, would incorporate your hand, and would write for himself. Psychophony would be the act of hearing voices, hear the spirits, and clairvoyance would be the act of see spirits or see what will happen in the future. We have some variants of the classical spiritism, like Umbanda, the scientific spiritism, atheist spiritism, North American spiritism. And the ideas that are used in spiritism, the concepts are usually used by the media. You can see here, these are 3 movies. You must have seen them, as Paranormal Activity, The Sixth Sense, and Ghosts, which are movies that usually adopt some spiritism concepts, like seeing or talking to spirits. So when the boy says, "I see dead people," so this is a concept from spiritism. So he can see spirits. So what about spiritism in Brazil? It's the fastest growing religion here. It's the 3rd religion with most adepts, the first being Catholics and the second evangelical. We have 4 million people that declare themselves as spiritists, but in Brazil we have something that's called religious syncretism, where you borrow some concepts from other religions, from other religion into your faith. So many people, for instance, this picture here on the top is Chico Xavier. He was a famous spiritist who used to do psychography. So people from all around our country came to his house in Minas Gerais, is a state of Brazil, for him to write letters from the other world. So he would incorporate spirits of deceased people and would write in place for him. So for example, if I wanted to talk to my father, I would go to him and he would incorporate my father, and my father would use his hand to write a letter for me. So in Brazil, you have this religious syncretism where you declare themselves as a Catholic, but many times you believe in spirits, you believe in psychography, you believe in the concept of spiritism. So it is estimated that supporters of Spiritism is 10 times more than these 4 million people. And concepts about mediumship is widely disseminated. So, and now a little bit about our research. We talked to over 2,500 individuals from the general population of São Paulo, our UHR research, between 18 and 30 years old. 226 were called into the Institute of Psychiatry for further assessments. So they were first screened with the prodromal questionnaires, and those who rated, who had a high score, they were called to the Institute, and we performed the SIPs by psychiatrists, and we saw that 98 were truly at-risk individuals and 124 were controls. To assess religiosity, we used the Duke Religious Index, the Durrell scale, which evaluates religiosity in 3 aspects. So first one is organizational religious activity, when you ask how often do you attend a church or other religious meetings. The second issue is a non-organizational religious activity. You ask how often do you spend time in private religious practices, such as prayer, meditation, or Bible study. And the third one is intrinsic subjective religiosity. This is how often you employ religious concepts in your life. A little bit about sample characteristics, I'll just skip that. What we saw is that when we compare the SIPS P4 item, which is perceptual abnormalities, it was significantly related to organizational religiosity. That is, the more the person had some perceptual abnormalities, the more he or she would go to a church or to a religious temple. We performed some path analysis with that and saw that this relationship, it endured. So here you see organizational religiosity having a positive correlation with perceptual abnormalities and having a negative relationship with ideational richness. So hallucinations and temple attendance. We hypothesized that temples would be a physical location and a social support group one can depend on for a set of practices that provide meaning. So people with these experiences would go to church to have a meaning for this odd experience. Also, higher the ideational richness would be negatively correlated with the religiosity, because people with higher ideational richness would be less dependent on communal organizations to provide meaning. So they would not need to go to a church or to give a meaning to that subclinical experience. Also, hallucinations were, we believe, they were often accommodated as a spiritual manifestation in the Brazilian culture. So, and now I give you the example of a girl I personally interviewed in our cohort study. She said she was experiencing voices, she was hearing voices in her house, and she was living there with the baby, and then she would go out of her house and seek for the voice, and then he would see that there was nobody there. He would go inside her house again, lock everything, and then try to sleep, but very afraid, very frightened. This happened for like 6 months. Then she moved to her mother's house, and then she kept hearing these voices there. She got very anguished, and then once she decided to tell her mother that she was hearing some voices, there were people calling her, but when she looked, there was no one there. And then her mother simply told her, "Oh, these are spirits. I also have this experience. Come with me to the church." And then they both went to the church, and she got relieved. She got much less stressed, and she gave a meaning to that voices. And the time I interviewed her, he was very calm, he was very happy with the baby, and she was still hearing the voices, but she would know that these were spirits and that she had to go to the church to deal with the spirits. So this is just an example, a practical example I saw this girl of how hallucinations can be accommodated in our culture. So religion and psychosis, is this a means of coping with psychotic experience, or does it shelter, does it induce psychotic experiences? So we have results. We looked at how these people went up a long time. So we reassessed 82 at-risk individuals. 3 of them converted to schizophrenia, 10 of them converted to other DSM-5 diagnoses, and 6 progressed along the continuum, the psychotic continuum, and had severe symptoms, but no diagnosis, no need of help. So in total, we would have 19 converters, or people that converted to psychiatric diagnosis or that were presenting severe psychopathology. Well, what happened with them when we saw at their baseline religious activity against controls? So when we grouped these people, we can see that there was a significantly higher private religious practice compared to non-converters. This was also controlled for age, lifetime cannabis use, and gender. That is, when we looked into those people, at baseline, they were more often practicing religion in their houses, like murmuring prayers or reading the Bible or doing private religious activity than those who did not convert. So on the one hand, we have like churches and religious organizations. They are used to cope with hallucinations. They are also an alternative to traditional medical help seeking for UHR individuals. They provide a normalization of subclinical psychotic experience. But on the other hand, we have private religious practices. They are related to an increased risk of progressing along the psychosis continuum. This means that private religious practices, they probably are an unsuccessful coping strategy, or they are a proxy for ritualization proneness often seen in psychosis. So it's like a double-edged sword here. So given that, and given the stigma related to the schizophrenia label, the low conversion rates in UHR, and the lack of mental health care resources in Brazil, would it do well or would it hurt to warn people now of psychosis risk? So this is really about a balance where we have on the one side, we have someone saved from schizophrenia, and on the other side, people suffering the consequences of a false positive risk diagnosis. So who would have who would weigh more? How many people would suffer the consequences of false positive? How many people getting stressed? How is equivalent to 1 people that we save from schizophrenia? This is a very complicated balance, but I would say that unlike other areas of medicines, this is not like, for example, pap smear, where you have a pre-malignant lesion, where you have a pre-malignant alteration that you know for sure that it will progress to a cervical cancer. So this is not like in other areas of medicine where you are sure, where you are certain that this is a pre-cancer lesion. But the case here is that UHR people, many will not progress along the continuum. Many will not convert to psychosis. So UHR concept is not like a pre-malignant lesion here. It's not, you are not sure that they will progress to schizophrenia. So in my humble opinion, it's still too early to tell people that they are at risk for schizophrenia. So what should we do here? we should promote public campaigns to destigmatize schizophrenia diagnosis. This would help a lot. So when you would tell people, you will not be afraid to tell people that, hey, you are in risk of developing schizophrenia, because you will not make them feel fear, because, okay, schizophrenia, but it has treatment, we can take medication, okay, then I will remain under your vigilance, and if I have any signs of schizophrenia, I will tell you. It would be a much more a simpler thing. So this is key for me to destigmatize the schizophrenia label diagnosis, or the psychosis label, improve mental health care delivery, and educate professionals regarding psychosis risk and stigma. I think the previous presenter also told about this. She reached about this issue. Focus on religious institutions and organizations that they might serve as an alternative way to help seeking, to help at-risk individuals who are symptomatic and help seeking. So this is very common. So you need to look into alternative ways of help seeking behavior, like we have here in Brazil. So just another example, this is me, a few pounds less than after the pandemic, but I went to this Voice Hearer Congress we had here in Sao Paulo. It was very interesting, and I met a researcher from Sweden, and I asked him, what would someone do if someone started to hear voices? And he said, oh, he would go to the doctor first. And I'm pretty sure here in Brazil, the first thing you will do is to go to a spiritist center, because it's a very widespread belief that people can talk to spirits here. So you have to look into this alternative ways of help seeking than traditional medicine. You have to look for these people there also. And also you have to enhance UHR's prediction paradigm, because so you would approximate our UHR paradigm to other prediction and preventative measures we have in medicines, like I mentioned about pap smear, or about other types of cancers, or of other diseases that we have a clear preclinical stage. So I would like to thank you all. This is my email. I will be glad to answer questions and any doubts you have. Thank you.
I'd really like to thank you, Alexandre, for your presentation, which was excellent. I am always really intrigued by the way that normalization within a public religious context in Brazil can be so helpful to people, and wonder what those elements are that might be used elsewhere outside Brazil. Also, I think you raise an excellent point about available resources. What does it mean to tell people they're at potential risk for something if they then turn around and say, well, where do I go? And there's not really any place for them to go. As that was a wonderful talk. I want to thank you very much. It's my pleasure now to introduce my colleague, Danny Koren from the University of Haifa in Israel, who is a good last speaker, because I think he turns all of this a little bit on its head with questioning whether we have the right kind of label at all, rather, sort of beyond whether we should label is if we do label, what's the best label to have. So it's my pleasure. I will now introduce Dr. Koren.
Thanks, Cheryl, for putting this symposium together, and for inviting me to be part of it. And thanks everybody for highly informative and thought-provoking presentations. I hope that you'll find at least some value in the ideas and data I'm going to present as well. I have to admit that I'm not overly hopeful, given the amount or lack of interest that these ideas have received over the past 10 years, but I'll give it a try anyway. So this is the topic or main thesis of my presentation. That is taking a glass half full, high-risk health approach to the at-risk state or at-risk diagnosis might be promising means to attenuate, if you wish, its risks, to attenuate the risk of the attenuated psychosis risk syndrome. So before, how do I progress? How do I? Before I introduce this idea, this is my professional identity, my professional self, and my statement of disclosure, which I have nothing to disclose in essence. And here is the here's the idea. So the main theme of what I wish to present, and the main goal of this presentation is to propose that a good or promising way to address the risks associated with the being at risk message. These are the risks that have been presented by previous presenters in this symposium, is to refocus this message on the half full rather than on the half empty part of the at-risk glass or at-risk state. And to grasp this notion, it might be useful to consider the following at-risk conditions in general medicine. So, for example, let's see if it goes. In general medicine, when people have minor hearing loss or major hearing loss or moderate hearing loss, we are referring to it as hearing loss that can be treated with hearing aid device rather than conceptualizing it or labeling it as a deafness risk syndrome or attenuated deafness that can be treated with anti-deafness device or devices. Another example for all of us who wear glasses, and think about yourself, whether you believe that you have short-sightedness or long-sightedness, or you believe that you have blindness risk syndrome or attenuated blindness that needs to be treated with anti-blindness devices, such as glasses. Another example is high-risk pregnancy, as opposed to miscarriage risk syndrome or attenuated miscarriage. And the final one, which might be the best one, the most nonsensical one, life-threatening conditions as opposed to death-threatening conditions or, if you wish, attenuated death. So based on these examples from general medicine, as well as similar examples from other domains, other areas, such as endangered species, endangered cultural or heritage sites, and that kind of stuff. We have recently proposed that reconceptualizing the at-risk state as high-risk health has a potential to address the concerns about the iatrogenic impact of stigma on patients, families, institutions, and society at large. So basically what we are proposing is that labels such as high-risk common sense or high-risk integration or high-risk mental harmony or whatever. I mean, the direction is important, not necessarily those particular examples. Makes much more sense than psychosis high risk or attenuated psychosis. In our view, attenuated psychosis syndrome makes the same sense as attenuated deafness for hearing loss. So if we believe that attenuated psychosis syndrome is a good label, we should launch a campaign within general medicine to rename conditions such as hearing loss, to rename it, to relabel it attenuated deafness, life-threatening conditions as attenuated death, and so forth. So that's this is the overall idea. It has been published in 2013 as an editorial in the Early Intervention in Psychiatry journal. If you wish, you may go back there and read it. And what I would like to do now is briefly present preliminary findings from 2 pilot studies that assess this notion, this hypothesis. They've been published as an abstract in Schizophrenia Bulletin about 2 years ago. The first study assessed the effect of labeling, that is psychosis high risk versus high risk common sense. This was in the time before psychosis high risk syndrome was renamed as attenuated psychosis syndrome. So that is why we are using this term. In the second study, we used attenuated psychosis syndrome. So that pilot study assessed the effect of labeling and symptom severity, mild versus severe, on public attitudes towards individuals at clinical high risk for psychosis. Participants in the study were adults, a random sample of 125 adults from the general community, general population. Mean age was 48.5, 55% were females, 43 were males. About 34% of them had a close friend, relative with a mental disorder, not necessarily psychotic one. And about 7% were mental health professionals themselves. The experimental manipulation included random assignment to 1 of 4 experimental vignettes describing a young adolescent experiencing either mild, akin to scores of 1 on 3 on SIPS, or severe, akin to scores of 4 to 5 on SIPS, prodromal symptoms, which will refer to the symptoms will refer to as either psychosis high risk syndrome or high risk common sense syndrome in an article that that adolescent found on the internet. So the story was, this is a description. I'm not going to read it. Description of that adolescent with mild symptoms. You probably have it on the internet, so you'll be able to read it yourself. This is a version of mild symptoms. And at the end of this is severe symptoms. And then the experimental manipulation was that adolescent was concerned about her or his condition. He felt a lot of distress. And first thing he did was to search the internet for information. And he stumbled upon an article describing very similar symptoms and signs to the ones that she or he was experiencing. And in the article, in one condition, it was said that these kind of symptoms might be a sign of psychosis high risk syndrome, and with a brief explanation. And the article also stated that it is possible today, there are centers where it is possible today to obtain help through therapies that decrease the risk for psychosis. The article concluded with a recommendation that one should apply to these kind of centers and seek help. And in the other condition, the same information, the same article suggested that these kind of signs and symptoms might be a sign of high-risk common sense syndrome, and that there are centers that offer therapies that protect and improves common sense, and it's highly recommended to approach and to approach these centers and seek help. So this was the experimental manipulation. The measures that we used were semantic differential scale to rate qualities or characteristics of the hypothetical adolescent, the attribution questionnaire, the AQ by Koren to assess self-stigma, and the social distance scale to assess public stigma, the desire to keep social stigma from an adolescent of this kind. And these are the results from the first study. First of all four groups were well matched on all basic socio-demographic and clinical variables such as age, sex, being a parent to an adolescent or young adult, being a mental health professional, having a first degree relative with mental problem, knowledge about mental health from media, etc. And these are the results, some of key results. In terms of self-image, you can see that the blue line is a high-risk health formulation or label. It is significantly higher than the psychosis risk syndrome. Likelihood of seeking help, again, there is a main effect for labeling, not for severity of symptoms. Level of hope, the treatment will help. Again, the same story. Level of fear of the patient, this is for the readers. Greater fear in the psychosis high risk. Patient's responsibility, blame for own condition. Main effect for psychosis risk. Worthwhileness of providing help, even against patient's will. Significant effect for high-risk common sense, but not for severity of symptoms. Desire for social distance, no significant effect. So this was the first study. Second study, we repeated the first study among mental health professionals. Voluntary sample of 172 mental health professionals, 6% psychiatrists, 56% clinical psychologists, 17% social workers, 90% art therapists, and 2% other. Is the age, gender, mostly females. The experimental manipulation was basically the same as in the previous study, with only one minor exception. The label psychosis risk syndrome and high-risk common sense syndrome were replaced with attenuated psychosis syndrome and common sense loss syndrome. This was after the time psychosis risk syndrome was replaced with attenuated psychosis syndrome. So we changed the manipulation in accordance with this change. The four groups were well matched on all socio-demographic and professional variables, level of seniority and these kind of stuff. Experience with psychotic patients and all these kind of variables. Once again, likelihood of seeking help, main effect for common sense loss, health loss compared to attenuated psychosis. Level of hope the treatment will help. Again, main effect for labeling. Self-stigma, main effect for alienation in the opposite direction. Self-stigma, stereotype endorsement, once again, main effect for attenuated psychosis. Discrimination experience, main effect for attenuated psychosis. and that's it. So what we have concluded from these preliminary pilot findings, these are the conclusions and limitations and future directions. So even though the experimental manipulation of labeling in the present study was rather minuscule and attenuated in nature, of particular importance in this regard are the unfamiliar and potentially cumbersome nature of the health label and the uncertain credibility of the source of information. The present findings provide first experimental support for the potential beneficial effect of a high-risk health or attenuated health cognitive reframing of the at-risk state on self-stigma, hope, and willingness to seek help. In addition, consistent with predictions based on the labeling theory, they suggest that self-stigma, help-seeking, and hope are more strongly affected by labeling than by symptom severity, as predicted by the behavioral stigma perspective. Finally, if further validated in studies that use larger samples and less attenuated designs, for example, using labels that have been identified in focus groups of patients, family members, and clinicians, and using more credible and vivid sources of information, such as videotaped expert-patient interactions, role-playing. The present findings may lay the foundation for future clinical trials that will examine the effect of glass-half-full, high-risk health reframing of the at-risk state on clinical and functional outcome among individuals at high risk. Thanks. If you have any questions, be happy to, or objections, be happy to learn and listen at the discussion at the end. Thanks.
Well, thank you very much, Danny, for a fantastic talk. I want to thank all of the speakers. This has been a really very interesting series of presentations grappling with the question of whether to tell individuals they're at risk for psychosis or not, or and even if we decide to do so, are there other ways to describe that to individuals, sort of as Danny had suggested with the half-full approach. I just have a very few slides. This is an article I published 4 years ago addressing ethical issues. This is just a framework to keep in mind that there are balancing ethical concerns in labeling psychosis risk. Certainly stigma is a threat to non-maleficence. We don't want to do harm, but paternalism is also a threat to autonomy. And if we intervene with individuals, either in clinical settings or in research or both, patients do have a right to informed consent. So it's an unusual question that you don't see in other parts of medicine. Though I do like what Danny, I like attenuated death syndrome. That does kind of drive his point home. Does the avoidance of terms like psychosis and schizophrenia possibly actually increase stigma because it promotes secrecy and shame? I just wanted to go over a few other studies that are data studies that look at stigma that I think complement the qualitative work that Carmel and Yulia Landa have done, and also the sort of the data studies that have been done by Alexandre and by Danny, including a vignette study. So this work has been done with Larry Yang in collaboration. And so we had found that administering the same vignette describing sort of a typical ultra or clinical high risk phenotype, the exact same vignette with different labels evokes different levels of stigma. And describing it as depression, there's not so much stigma. Describing it as schizophrenia, there was a lot of stigma, especially socially distancing that Danny had referred to. And psychosis risk also evoked a lot of stigma until we also had a condition in which we had just really 2 or 3 sentences saying what psychosis risk is. And when that was included, the stigma evoked was more at the depression level. We've also grappled with whether the stigma is related to the symptoms themselves or to labeling. It seems another Koren, I don't think that was me, thought that labeling mattered. I've had the hypothesis that symptoms matter more. When we did this study, Larry Yang and me, and this is published in 2015, we found that youths with the CHR label were aware of stereotypes but did not endorse them, and by and large described their negative stigma effects like shame and discrimination being related more to symptoms. Whereas labeling, on the other hand, I mean, there was also some negative effects, but people also described feeling understood, hopeful, relieved, sort of having an explanation for what they experienced, which I think is in line with some of what Carmel described. I also, I want to end on this note, that recently Larry Yang and colleagues, myself, published a study showing that most youth who are identified as CHR don't really identify that label as having the greatest impact on them. And there's a lot of comorbidity among people who are CHR in terms of depression, substance abuse, different anxiety disorders. And I think we want to keep in mind for these individuals now that they're called just CHR, clinical high risk, and so few people develop psychosis, but so many develop other disorders, that actually there have been 2 requests for applications from NIMH, very large grants to really study other outcomes beyond psychosis and biomarkers of psychosis, but also other outcomes as well. So the CHR designation is not just psychosis anymore at all. And so at the beginning, I had said that if people had questions, they could email the different speakers. So I've put everybody's email up. And also in the introduction, SIRS asks that when you use social media regarding this symposium and others, that use the hashtag of SIRS 2020 or SIRS. And these are some of the questions that I have put together also from input from others. Now as we do the Q&A, someone had asked if attenuated psychotic symptoms should have a new name in the DSM-5, and certainly that's something that Danny might have some thoughts about. I'll let Danny take the lead on that.
All right. Well, as you might guess, I certainly believe that we should adopt a different label than attenuated psychosis. What that label might be, I think, is an issue for focus expert groups, patients, maybe family members should be able to come up with a better label, one that focuses on universal functions that are compromised rather than on attenuated psychosis. So,
do you have any candidates?
If I have any candidate, well, the candidate that we used in our study is common sense, attenuated common sense or common sense loss, similar to hearing loss or something like that in the examples that they used. But I'm aware that this is not, this is admittedly, this is a rather cumbersome or awkward label. So I'm not sure it should be this one. In fact, rather convinced this is not a good candidate. But I believe that if we experts, specialists, and patients put our heads together, would be able to come up with a much better label that would be less stigmatizing, less traumatizing, less catastrophizing, and this kind of stuff. One which would focus on loss of a universal function. This could be mental harmony, integration, whatever. I mean, these are kind of universal functions that are lost, so that we can tell people, not only in terms of the label, we can communicate them. Look, the bad news is that some of the your abilities, faculties are compromised. But good news is that they're still intact, and there is a lot to build on. And our job is to protect and reinforce these capacities, these faculties, rather than prevent a catastrophe. I mean, if we don't do that, a catastrophe such as psychosis might take place. But the focus of our communication should be on the and the focus of the label that we use, the diagnosis, should be on universal loss of a universal function, rather than on emerging risk of emerging pathology or catastrophe. That's.
And can I ask Alexandre and Yulia to also comment on the same question?
Absolutely. This is such an important and interesting question. And I also agree that we probably don't yet have an answer, and we might want to do more research, asking patients and their families about their opinion. We actually did conducted qualitative interviews with patients 15 patients who were diagnosed with schizophrenia, and we asked them about the period before it all started, and if they would have liked that somebody would tell them about the risk at that time, and if somebody would tell them, what would they like to hear, how that should be called. So they came up with different suggestions. One was at risk for mental illness. Another was you might be more susceptible for developing a particular symptom. So suspectability came up. And most importantly, patients and family talked about what would it mean. They would just need to really understand what are they experiencing now, and what they could do to prevent the further development of the symptoms. How can they make it better? So I don't have an answer, but more research is needed. Potentially another label could be helpful, and it's very important that we have a very good explanation, whatever this label will be, what it means for patients that they can relate to.
Thank you, Yulia. Alexandre, any thoughts?
Yeah, great. I think that changing the label would help, but it would not address the root of the question, because, for example, we made a great effort to destigmatize hysteria, but now the stigma comes to borderline personality disorder. So I fear that the stigma may migrate from schizophrenia to the new name. So the new label. It would help, but my fear is that this would be for a short period of time. To address the root of the question for me would be to tolerate what the concept of schizophrenia and roles. That is, people with odd behavior or with perceptual abnormalities. So if you tolerate them, because currently there's a wall between normality and these people and what they experience. So if you could remove this wall and act like normalize, okay, you hear voices, but you do not have a disorder. You might have a disorder, but you still do not have. So this would turn them not into outsiders. So this would address the root of the question for me.
I think also the CHR designation now is associated with so many other outcomes. Though to get into the category, right, you have to have some kind of attenuated psychotic symptoms. It's very interesting. I guess focus groups would help. I agree with the idea of not backing down entirely from psychosis, but we did do the vignette study that showed that just a little bit of information about what we mean by the diagnosis can be very helpful, at least with public stigma. I'd like to thank Matthew Dobbs, who has been running this, who's wonderful. And he's reminded me we have fewer than 10 minutes left. Since we're an international symposium, I thought that perhaps in these remaining 10 minutes, we could focus really on some of the cultural differences that have come out. So when I listen, and I've heard you before, Alexandre, and seen this data, the idea of individual, I remember, I think you told me a story of somebody a young woman who heard a voice and she was terrified, and she told her mom, and her mom's like, well, I hear voices too, let's go to church. And everybody at church was hearing voices, and she didn't have the cognitive deficits that you see in schizophrenia, but she had a lot of hallucinations. I think you have a colleague in Brazil who has studied these individuals. They work, they're functioning, they get married. If they have sort of hallucinations in the absence of, say, like negative symptoms and cognitive deficits. I was really impressed by that, and so I'd be curious to hear from Yulia and Danny. When you listen to Alexandre, are there parts of that kind of normalization that you think you could incorporate in the context where you are in New York City and in Israel?
This is a very interesting question, and I think that's actually exactly what we want to do. So we want to normalize patient symptoms and experiences, and we want to find good ways of normalizing them. In terms of like here in New York, for example, we have a voice hearing movement where people share their experience of voice hearing and they learn from each other. They talk about positive aspects of these experiences and difficult aspects of these experiences, and they learn to navigate through these experiences. In other cultures, for example, in shamanism, voice hearing experience have been considered a very special experience that only a person at a higher level could actually achieve. In shamanism, people have rituals of how to facilitate this experience and how to navigate through that. So this is a spiritual experience. I think CBT, cognitive behavioral therapy approach, also specifically deals with that by using teaching people how to respond, think about voice hearing experiences, particular voices, how to control these experiences and not have these experiences interfere with people's life and happiness. And if it does not interfere, we don't need any treatment. If people have certain psychotic-like experiences and they are fine with that, they can continue with their activities and have a happy life. I think we are not needed as professionals to help them out.
Thank you, Yulia. That's a lovely response. I think we only have about 2 minutes left, and I want to point out, I'm sorry I didn't say this earlier, but here in the kind of gallery and Q&A, Carmel is not here, I think because it's the middle of the night in Australia, and so when this is made available, her comments may be appended to it. I think this is our last question, but I did ask Danny if he would comment.
Yeah,
so
right. Is that still desired? I'm happy to.
You get the last word for the whole thing. Is that all right with you, Alexandre? Anything to add before Yulia? Okay, Danny, you get the last word.
All right. Two quick sentences. First, with regard to your questions, I think that the use of playfulness, imagination, irrational beliefs is universal and common to all cultures. The context in which they take place may be different, religions, cults, whatever. So the use of culture to normalize, I can see myself using the kind of context, social context, be it religion or something else, to normalize these kind of experiences. But there is a common ground to all of them. I hope I'm managing to make some sense. So I think there is a shared component and a unique component to normalizing. The shared component is imagination, playfulness, irrational beliefs, and these kind of stuff, rituals that go beyond reality. The unique component is the kind of religion, the kind of culture, and that kind of stuff. And one more brief comment going back to Alexandre's previous answer. I think that we should be careful not to reduce the issue of labels to stigma alone. I agree with Alexandre that if it is only a matter of stigma, stigma would immigrate to the next label. But as Carmel reminded us, it is also a matter of hope for recovery. And this is a whole different issue. And in my view, life-threatening conditions and death-threatening conditions, even if stigma that is associated with them is the same, it's not the same in terms of hope. And attenuated blindness and short-sightedness may be the same in terms of stigma, but they're not the same in terms of hope. And the same thing applies to attenuated psychosis, in my view. Stigma might immigrate to the next label, but hope for recovery and expectations for recovery and overcoming the crisis are very different in my view. I mean, obviously, this is an empirical question that needs to be addressed, but my prediction is that this is not the same as stigma immigrating from one label to the other.
That's very nice. It's sort of saying that not only do we have the responsibility to not do harm, but we also have the responsibility to instill hope
Right.
as healers.
Absolutely.
I have some chills from that. So I think this has really been wonderful. Thank you all for participating. It's really a pleasure, and I look forward to the next conference when we can all meet in person.